This is one of the in a series of webinars organized by KNH, and today's webinar is organized by KNH in partnership with KENCO. KENCO is a Kenyan Network of Cancer Organization. It's the umbrella body of organizations that deal with cancer awareness, support, research, and advocacy in the country, and it's quite a number of them. Today we will have some time to learn about chronic myeloid leukemia, and we have our presenters. One of them is a patient who will give us a lived experience with CML. Another one is a doctor, an oncology pharmacist, who will give us the details, scientific details that might help us understand better about the CML. My name is Elo Mapelu. I'm the chairman of KENCO. I'm also the chairman of Hands of Kenya, which is a group, support group of patients who have CML, that's chronic myeloid leukemia, of which is our topic today. And before I could invite the speakers, I would like to just do a quick introduction on leukemia, just so that we might be able to know where we're coming from before we get the perspective of the doctor. So leukemia is a blood cancer, and it's caused by a rise in a number of blood cells in your body. These blood cells, which are white blood cells, crowd out the red blood cells and platelets that your body needs to be healthy. So the extra white blood cells don't work right, and that's how it ends up being leukemia. And there are various different symptoms, which I'm sure the doctor will touch on. The common ones will be weakness and fatigue, easy bruising and bleeding, fever and chills. I'm sure the doctor will mention a few more. Some of the risk factors that can be attributable to leukemia include smoke, and if someone is exposed to a lot of radiation or certain chemicals, if someone has a family history of leukemia, and if someone has some genetic disorder like Down syndrome, then they're exposed to getting that. But I'm sure the doctor will give us more on that. I'm just saying this so that we can prepare ourselves to what the doctor is about to give us. But there's not generally leukemia, but there are many types of leukemia. There are 4 major types of leukemia, and leukemia is grouped by how fast it develops and gets worse, and by which types of blood cell is involved. Those are the 2 main grouping of leukemia. And the first group of on how fast it develops is divided into acute and chronic leukemia, where acute leukemia happens when most of the abnormal blood cells don't mature and can't carry out normal functions. It can get bad very fast. Chronic leukemia happens when there are some immature cells, but others are normal and can work the way they should. It gets bad more slowly than acute form. And the second group is what type of cell is involved. Is divided into lymphocytic and myelogenous leukemia. Lymphocytic or lymphoblastic leukemia involves bone marrow cells that become lymphocytes, a kind of white blood cell. And myelogenous or myeloid leukemia involves the marrow cells that create red blood cells, platelets, and other kinds of white blood cells. So like I said, there are 4 main types of leukemia. There's acute lymphocytic leukemia, there's acute myelogenous leukemia, there's chronic lymphocytic leukemia, and there's chronic myelogenous or chronic myeloid leukemia, which today is what you're going to be focusing on. So chronic myelogenous leukemia, one may not even be diagnosed until they're fairly old. But when someone does their routine blood tests, then they are able to to get a diagnosis. And before we bring on board Dr. Dennis Mbuve to speak to us about that, I wish to bring Sarah Wanjiko Mararo, who is a chronic myeloid leukemia, which is CML patient, and has been for some time. She'll let us know a bit about herself. Sarah is also a nurse in Kenyatta National Hospital, and she'll tell us a bit about her lived experience with the leukemia, how she got to know that she has it, and how she has managed to take care of herself and treat the disease. Fortunately, leukemia, CML, unlike other types of leukemia, is very easily treatable and is very positively treatable. And Sarah will give us a bit about what she currently is on in terms of treatment. So Sarah, are you ready to share your story with us?
Thank you very much, Chair. Hello. I hope everyone can hear me. So I'm a nurse, like Elo said. My name is Sarah Mararo. I work at the Kenyatta National Hospital, and I'm a CML survivor. I have been on this journey for the last, could say 2 years or thereabouts. Before I had CML, I used to get a lot of, I just got straight to my story. So I used to get a lot of bloating. Those who know me know I could just eat a little food and I could feel, you know, fullness. And then I could easily get fatigued. I worked in a maternity unit before, so I could get easily fatigued at a small task. I used to get a lot of night sweats at night. And the other thing was that before I got diagnosed, 2 to 3 days before I got diagnosed, I had a kind of a swelling on my left side of the stomach. And it was during COVID times. So I used to work out. So I thought it's just some tension of the muscle. And everybody knows medics are the last people to go and seek medical attention. So I did ignore it until this one day after work. I couldn't sit, I couldn't stand, I couldn't sleep, I could not do anything. And so I was meant to go back to work the next day. So I took a painkiller, which didn't last for so long. So I called my immediate supervisor just to tell her that I won't make it to work. Fortunately for me, I happened to work in a hospital, so accessibility to healthcare was not that bad. And when I got to staff clinic, it was treated as an emergency. I immediately got an ultrasound done because it was obvious after palpation that the left side of my stomach was swollen. So I got an ultrasound done, and immediately when the results came out, they noticed that the spleen was quite enlarged. So I did a full hemogram test and a malaria test, you know, everything that leads to reasons as to why the spleen would be enlarged. The results came back. Malaria test was quite negative, but the white blood cells were quite elevated. So I was written for a consult to go to hematology, where I was introduced to Dr. Matilda. And Dr. Matilda is the one who broke the news to me and told me that probably all the signs, because my white blood cell count at that moment was 225. Yeah, 225. So 225. So she recommended that I should do a BCR ABL, which she explained that is the gene that is created. So she needed to know the levels and to confirm using the bone marrow aspirate, which I did the next day. And within 3 days, I'd gotten my results back, and clearly I was suffering from chronic myeloid leukemia. So she sent me to Nairobi Hospital, where I was introduced to Professor Abinya, who introduced me into the program under Max Foundation. In the program, that's where we started on Glivec, which is the current medication that is the first line medication that is being offered. I immediately started on Glivec, and within 2 weeks, most of the signs and symptoms that I had disappeared. My spleen was back to its normal size. The night sweats were gone. And the fatigue was much less. Oh, I also had a lot of weight loss. I had gone all the way down to 43 kgs. So within 2 weeks, I could feel like myself again. So everything was normal for about 3 months until again, of course, every drug has its side effects. So I got side effects from the medication. The Max Foundation and the Nairobi Hospital have this program whereby you have to come for clinic every month. So it's very easy to detect abnormalities or things that are going wrong. So the doctor was very quick to notice that the drugs were really suppressing the bone marrow. So anyway, it was titrated back to how it should be. And I'm currently on Glivec 3 tablets, 300 milligrams. I am doing well. I'm living a very normal life. I'm 17 kgs heavier from the last time. And I think I'm leading the normal life. I don't think if you saw me working, there's anything different. No, I'm leading a very, very, very normal life. I'd like to thank the Max Foundation, Professor Abinya and the Nairobi Hospital team and Novartis for, the program, because it's really encouraging. We get to lead a normal life because of them. I think that's all I have to say for now. Thank you, Elo and the team.
Thank you very much, Sarah, for sharing your story. It's indeed a very encouraging story, a very inspiring story, because there are not very many stories you hear from people who are suffering from cancer, to hear that they're doing well on treatment and they're back to living their normal lives. So it's inspirational to hear you say that. It's also good to know that there is treatment available for CML. And what you didn't tell us, and I'll take this opportunity to say that this treatment is available free of charge to anybody who's been diagnosed positive with CML. It's a program that is funded by Novartis, among other pharma, and it's being run by Max Foundation. And we have doctors like Dennis Mbuvi who give their service for free to make sure that this medicine is accessible to the patients who need it. So without waiting for long, I know there might be some questions for Sarah. I guess then you may be able to put it down somewhere, and then we'll be able to see the chat. We'll be able to see, and then she can be able to respond back to you. But without wasting any more time, I'd like to introduce Dr. Dennis Mbuvi, who is an oncology pharmacist at the Nairobi Hospital, and he's the one who handled these drugs that we've heard Sarah mention, and he's going to tell us more about it and about more about the clinical presentation of CML. So Dr. Mbuvi, you're welcome.
Thank you very much, Mr. Mapelu, Mr. Chairman. Thank you, Sarah, for sharing your story. I think we are running out of time, so I'll go direct to the presentation. So as I start, my name is Dennis Mbuvi. I'm a pharmacist at the Nairobi Hospital. I practice at the cancer center, where we, as intimated by the chairman, we run one of the clinics free of charge, courtesy of Max Foundation Novartis, for the treatment of CML. So we'll just go direct into what has brought us here today. we'll discuss chronic myeloid leukemia. So we are currently in the actually October is Cancer Awareness Month. We just the other day on actually on Saturday on 24th of this month we celebrated the World CML Day, which is usually on the 22nd of September, but the celebrations were on Saturday. So this comes at the best time to learn more about this disease. So chronic myeloid leukemia. We are going to be looking at the introduction to this cancer. We are going to look at how the pathological process that leads to this particular disease. We are going to look at signs and symptoms. We are going to look at an overview of the diagnosis, and then we are going to be looking at the treatment and where we are in terms of management of this disease. So what is chronic myeloid leukemia? Chronic myeloid leukemia is a slow-growing cancer. That's the term chronic. It is a cancer that starts in the bone marrow, following a mutation that we're going to demonstrate in a few minutes. This particular cancer is one of it's more of it falls on the rare side of leukemias as compared to the other types of leukemia and other hematologic malignancies. This particular cancer of the blood starts off slowly and progresses over time. And as one of the survivors has talked about, during diagnosis, you may have fever, fatigue, easy bleeding, anemia, infections, and swollen spleen or splenomegaly, as she quite well put. You might also have other signs and symptoms that we'll see. So CML was actually one of the very first leukemias to be demonstrated both clinically and via the various tests that were available back then. There were reports of leukemias in the late 19th century, and most of those were thought to be of the chronic kind. During the 1960s all the way to the 1980s, we saw a lot of development in the area of molecular biology, and we saw a lot of identification of the molecular basis of a lot of these diseases. So this is where we actually learned about what actually causes the chronic myeloid leukemia, and that's where we started to look at how we can actually target this particular disease. So when you're looking at the hematologic cell lines from the bone marrow, as where my cursor is right now, this is the potential hematopoietic stem cell, from where we get two lines of cells from the bone marrow. We get the myeloid progenitor cells and the common lymphoid. The lymphoid will later form lymphocytes and the natural killer cells, whereby then myeloid will form the red blood cells, the other white blood cells, including eosinophils, neutrophils, basophils, and all that. The platelets also come from this line of hematologic cell line. So what we are interested in is the myeloid line, that where this cancer comes from. So as we look at the hematologic malignancies, we'll have a look at in general, we have lymphoid and myeloid malignancies. Amongst the lymphoid malignancies, we have the lymphomas, myeloma, multiple myeloma, and the lymphoblastic leukemias. At the myeloid cell line, we have acute myeloid leukemia, the chronic myeloid leukemia, and a few subsets which are not of significance right now. Chronic myeloid leukemia accounts for about 15% of all leukemias. In Kenya, the incidence is around 1.2 cases per 100,000 population. The male gender is seen to be at a higher risk than the female gender. Median age of diagnosis worldwide is 55 to 65 years. However, studies have shown that in Africa and in Kenya in particular, the median age of at diagnosis is much less, at actually around 35 years, as demonstrated by one study at the Kenyatta National Hospital. So what exactly causes this leukemia? Chronic myeloid leukemia is one of the cancers that has been shown to be caused by a single genetic mutation. So initially, there's a genetic change that takes place in one early cell in the bone marrow. That is a stem cell or an early myeloid cell in the bone marrow. This immature cell transforms and becomes a CML cell, rather a leukemic cell. And this cell is now what divides and multiplies and produces the clinical disease that we see. So it is a disease of clonal expansion. Starts with one cell that undergoes a change, and this cell is now what gives daughter cells, which later become a problem clinically. So this change is as demonstrated here. So once upon a time in the bone marrow, one of the cells undergoes a mutation. As we all know, mutation is changes in the genetic makeup. This particular mutation is called a translocation mutation. It involves two chromosomes. There is a chromosome 9 and chromosome 22. These two chromosomes carry different types of genes. Chromosome 9 carries one of the genes that it carries is an ABL gene. This so it's called the Abelson proto-oncogene. This particular gene codes for a normal protein, which is an enzyme called a tyrosine kinase. And on chromosome 22, we find there's a BCR, which is a breakpoint cluster region. These two chromosomes undergo a mutation whereby they exchange genetic material, and they form, as you can see here, this translocation mutation here gives rise to these two new chromosomes. A changed chromosome 9, which doesn't give a lot of problems, and this chromosome 22. This particular chromosome is a shortened form of the normal chromosome 22, and it contains a new fusion gene. A fusion gene is a new gene that is formed by fusion of two previous genes or two parts of the genetic makeup. And this new gene is now called the BCR-ABL gene or BCR-ABL gene. And this is what causes all the issues we see in chronic myeloid leukemia. So this new chromosome 22 is called the Philadelphia chromosome, and it is the hallmark of diagnosis or identification of chronic myeloid leukemia. This new gene, the oncogene now, it's the ABL, as I said, is an pronto-oncogene, meaning it's a gene that if changes occur to it, it can become an oncogene or a cancer-forming gene. So the BCR-ABL is a non-oncogene. It's a fully fledged oncogene, meaning it causes cancer in itself. So the BCR-ABL now, as a gene, codes for a certain protein. This protein is also a tyrosine kinase, such as the normal ABL. But this particular BCR-ABL gene protein or tyrosine kinase, which now sits in the cytoplasm of the cell, it causes a lot of issues in the cell because it's an abnormal gene. And being a tyrosine kinase, it leads to phosphorylation of a lot of proteins in the cytoplasm, activating a myriad of signaling pathways or signal transduction pathways in the cell. These particular signals in the cell improve the cell survival of that particular early cell that has undergone this change. So these are some of the changes that occur in this cell. This particular cell becomes harder to kill by apoptosis. So there's reduction of apoptosis or this programmed cell death by inhibiting certain mitochondrial enzymes. The cell is able to live for long. Actually, these leukemic cells are immortal. So you have a new immortal cell which does not die when it's supposed to die. Increased proliferation of this particular cell is also activated. So the cell divides faster than it should and produces more daughter cells than it should. And so because the daughter cell will also have this mutation, this leads to a clonal expansion of that particular line. This also leads to decreased adherence of the leukemic cells to the bone marrow stroma. So the new cells, the new leukemic cells that have been produced, they do not adhere to the stroma of the bone marrow as they should, and they are more motile, and they can spread easily, or they can spill easily into the blood and other tissues. There is also increased genetic instability due to additional chromosomal abnormalities. So this particular cell, although we are saying that CML is caused by one particular mutation, eventually, following several cycles of division, there is a lot of mutation, accumulation of mutations that eventually change the genetic makeup of this disease. So as much as it is formed by one genetic issue, it can form a lot of other genetic issues downstream. So this is a pictorial demonstration of what happened. Here you have a Philadelphia chromosome positive stem cell following the mutation. Differentiation of this particular cell causes production of leukemic cells, which, as we shall see, can produce stages of chronic myeloid leukemia as seen here. And these particular issues in the cell, as demonstrated here, lead to a lot of issues, including DNA damage, activation of this particular signaling pathways, which lead to longer survival of these particular cells or cell lines, and also reduced death and increased proliferation. Progression of CML as a clinical disease is through three major stages or phases. We do not term leukemia or any other malignant, any other hematologic malignancy as being staged as the solid tumors. So here we are talking about phases. And these phases, the first phase, the first stage of chronic myeloid leukemia is usually the chronic phase, where now we have fewer blasts or immature myeloid cells, either in the blood or in the bone marrow. So less than 20% of up to 15% of blasts in the bone marrow of the blood, we'll term that as a chronic phase, which lasts to around 6 years, 5 to 6 years. This can be followed by an accelerated phase where we see worsening disease, where now we see issues with massive splenomegaly, fatigue, tiredness, and other issues. This can be followed by the blast crisis, which is frequently and it leads to mortality in a very short time, 3 to 6 months. And this is caused by blast crisis, where we have a lot of blast or immature myeloid cells, either in the blood, up to more than 30% in the blood or in the bone marrow. Now, the clinical presentation of chronic myeloid leukemia, as we say, as we've seen, starts off quite vague. We see a lot of what we call symptoms that are also symptomatic of other or indicative of other diseases. Patients are usually in setups where there's a lot of medical high incident of suspicion. Patients usually are diagnosed, around 50% are diagnosed by routine blast tests, whereby in setting in Africa and in other countries, in other low resource settings, we see a lot of presentation of high CML disease burden. So patients usually present with massive splenomegaly, weight loss, fatigue, anemia, ease of bleeding, pain, either left quadrant, upper quadrant pain, or shoulder pain, or any other symptom. And usually, following a blood test, we are able to suspect CML, and then we go ahead and do a definitive diagnosis. In one local study in in Kenyatta National Hospital, actually between 1992 and 1999, 90.7% of patients who are diagnosed with CML had a massive splenomegaly diagnosis, showing that we are diagnosing our cancers very late. And this also has may result in worse outcomes in our setting. So what do we see when we look at the blood film of a CML suspected patient? We see a lot of, now when we have this mutation that occurs in the bone marrow, the clonal expansion of these cells, the myeloid cells, leads to spillover of these cells into the blood. And this leads to an increase in the white blood cells count in the blood. And this might lead to now the symptoms that we see, because now the normal hematopoiesis process is not able to take place. And we also have issues with invasion of other tissues. So leukocytosis is common, and usually always the white blood cell count is always raised up to even 500 billion cells per liter. Basophil and eosinophils may be increased. The platelet may be normal or increased. That is around 33% have thrombocytosis, but thrombocytopenia is rare with CML diagnosis. Hemoglobin is reduced in a third of patients, less than 10 grams per deciliter. When we do a peripheral blood smear, we see blasts, of which can be indicative of the phase of this patient is in. Less than 10% will tell us that this patient is probably in the chronic phase. 10 to 29% indicates an accelerated phase, whereby 30% or more of blasts in the peripheral blood, as seen in the peripheral blood film, shows blast crisis. Generally, we see a left-shifted hematopoiesis with predominantly neutrophils and their precursors. So we see a lot of myelocytes, metamyelocytes, and promyelocytes in the peripheral blood, which they are not supposed to be there. We might also see nucleated red blood cells, which are also an indicative of this malignant disease. So this is what you see in the peripheral blood smear. When you look at, this is the normal smear, where you see a few white blood cells here, a few neutrophils, and the red blood cells forming bulk of this. Then the small specks, these are platelets. In the CML patient, you will see a lot of myeloid cells here. You will see a lot of white blood cells. Some are blasts, such as this large, with a large nucleus. You will see a lot of hypersegmented neutrophils, as you see here. A bit of an increase in eosinophils, and decreased red blood cell count here, as you can see. And therefore, sometimes anemia in a third of the patients. So presentation in the bone marrow appears hypercellular. A normal bone marrow has islands of cellular areas. But in CML, the bone marrow is hypercellular, meaning there is too many cells in the bone marrow. There is myeloid hyperplasia with reduced erythroid ratio. So that means we have less of the red blood cells being formed, but more of the white blood cells. The marrowblasts again can tell us if this patient is in chronic phase, or in the accelerated phase, or in the blast crisis. There is increased reticulin fibrosis, as can be seen by staining, and there are some biochemical abnormalities can be shown through chemistry in the lab. So after we see all this, the patient has presented with all these symptoms. We've had our high clinical suspicion of this disease. We've sent this patient for a blood count. We've seen all these issues and also the bone marrow aspirate. Now, to do to have a definitive diagnosis of this disease, we must carry out karyotyping of the bone marrow sample, and this is done by identifying the Philadelphia chromosome. So the karyotype will show a clear reciprocal translocation. It will show the shortened Philadelphia chromosome, which now will tell us definitely that this is a CML. This is CML that you're dealing with. There is a positive 95% of CML patients will have a positive karyotype with the Philadelphia chromosome. And the rest of the patients, about 5% or less of the patients, might have the transcript as shown by the other tests that I'm going to talk about. And some patients might have the clinical disease, but may not have any chromosome or the BCR-ABL transcript. And these patients are treated different because that is termed as a different disease altogether. So therefore, the Philadelphia chromosome is the hallmark of diagnosis of CML. Once we have seen the Philadelphia chromosome in the karyotype, then we'll correlate this with the blood qualitative reverse transcriptase PCR or polymerase chain reaction, and this will show the transcript or the gene expression of this particular Philadelphia chromosome. And the complete blood count with differentials will also give us an idea of what we're dealing with. And then we'll do cytology as we've seen. And then rarely FISH is indicated or fluorescent in situ hybridization. This is usually where maybe we are not able to do the karyotyping, and it can also be useful in correlating this diagnosis. So when you're doing the diagnostic workup for CML, we are looking at the blood counts as seen here. We are looking at the cytology, the bone marrow, the karyotype, and then the qualitative reverse transcriptase PCR for the genetic expression of the BCR-ABL. So for diagnosis, for baseline diagnostic, we use these three plus the PCR to do the diagnosis, where we say the karyotype is the hallmark. Now, to assess response to treatment, as we shall see in the later slides, we do blood counts and differentials every 15 days until we have a complete hematologic response. That is, we are not seeing any leukocytosis reduces, disappears from the peripheral blood film. And thereafter, we do it to also monitor side effects to the treatment. The bone marrow cytology is not done routinely to assess response, nor to monitor response to treatment. The karyotype is done every 3 months until we have a cytogenetic response. We also do it every 6 months until a complete cytogenetic response. Complete cytogenetic response means the karyotype does not show any Philadelphia chromosome. The FISH and the quantitative PCR can also be done. The quantitative BCR is used in monitoring of response every 3 months. And if we want to put this patient on a treatment-free remission, then we can do it every 4 to 6 weeks. Mutational analysis to assess failure, treatment failure, is also done, but this is rarely done, but can only it's only indicated maybe in the accelerated phase or the blast crisis phase, where we want to see if there's any mutation that we can bypass to try and put the disease in remission. So treatment of CML has been around for a very long time. Since we identified the disease, various treatments have been tried and tested. The very first treatment for CML and leukemia was arsenic. Arsenic, to be precise, was potassium arsenite. Very toxic treatment, but as we all know, like treatments evolves over time. This was called the Fowler solution. Irradiation followed by chemotherapy in 1946 was done, was used to treat leukemia. We started with the nitrogen mustard, then we went to busulfan, which is chemotherapy, hydroxyurea. And then transplant was an option. The allografts, the bone marrow transplants were done from 1979. Interferon alpha has been used since 1982. Later on, we see the hallmark of now CML treatment coming up in the early 90s and introduced in 1998 with the first BCR-ABL tyrosine kinase inhibitor, which they call the imatinib, and that's what we are using and up to today. Doesn't mean the other treatments are not useful, but they have fallen. We are no longer. We have a safer and more effective treatment, so we only use them in certain conditions. Treatment of CML currently is done using the tyrosine kinase inhibitors. So this is a standard for treatment for chronic myeloid leukemia. Chemotherapeutic agents are also used, busulfan, hydroxyurea, cytarabine, interferon alpha, specifically the pegylated interferon alpha 2A, and the stem cell transplantation, which actually only remains remains the only treatment, definitive treatment cure for CML. Other treatments that can be done include splenectomy to remove this spleen, splenic irradiation, which is rare because of the issues with adhesions and the side effects of the same. Chemotherapy for CML, as described, can be done with hydroxyurea or hydroxycarbamide. Hydroxyurea is used initially to reduce the white blood cell count and can also be used in resistant disease or in relapse. And it does not offer any molecular or cytogenetic response. So it does not reduce the appearance of the Philadelphia chromosome or the transcript, the BCR-ABL transcript. So it's no longer used for long-term treatment because it doesn't have any better long-term prognosis. The dose is started at around 20 to 30 milligrams per kg orally per day. Busulfan is useful in when we are doing allogeneic stem cell transplants. So it is used in the induction and the maintenance regimens for remission for the transplantation. It's not used in treatment of chronic phase chronic myeloid leukemia because of issues of severe side effects such as delayed myelosuppression, fibrosis, including pulmonary and cardiac fibrosis, and others. So you have the doses for induction and maintenance as shown there. Interferon or interferon alpha 2A is a useful medication in certain situations. It can be combined with cytarabine or tyrosine kinase inhibitors to improve outcomes, especially in resistant disease. It may be used during pregnancy where we need to interrupt treatment, tyrosine kinase inhibitor treatment because of the issues with fetal harm, and it can be used safely in that population. It's also under investigation, as well as been given an orphan status for use with high dose imatinib to achieve a deep molecular remission for candidates who wish to discontinue treatment and wish to go into the treatment-free remission. Allogeneic stem cell transplantation remains the only cure for CML, although the indications for it have gone down because of the effectiveness of the tyrosine kinase inhibitors, because most CML patients, especially in the chronic phase, can live normal lives as comparable to those people even without CML. So the chronic phase CML patients may receive the transplant due to the mutations that render this cancer resistant to take tyrosine kinase inhibitors. or in the advanced stage of the CML, either in the accelerated phase or the blast crisis, where it's the only option where all the other treatments have failed. The hallmark of CML treatment is targeted therapy. Targeted therapy forms a big subset of treatment for cancer, where we have targeted treatment as opposed to the traditional chemotherapy, which also deals with all fast dividing cells. So here we are dealing with targeted treatment at a particular either molecule, enzyme, or tissue. So this started with understanding the molecular basis of malignancies in the 1970s. And then we saw the logical rational development of the small molecules, which are very, very, very targeted. And now later on, now this was shown to inhibit growth and proliferation of cancers, and could also induce apoptosis. And now they are used in the control of these malignant diseases. Tyrosine kinase inhibitors. These are a form of targeted therapy as demonstrated in the previous slide. They work by inhibiting tyrosine kinases. Now, tyrosine kinases are normal enzymes. The body contains many, many tyrosine kinases. One example is the insulin receptor, which is a tyrosine kinase by design. Now, some tyrosine kinases are highly involved in the activation of proteins involved in the cell proliferation, apoptosis, and various other processes that either tell the cell to grow, to divide, to survive, or to die. So when there's an issue with tyrosine kinases in the body, there's already an issue with the proliferation of these cells, or the growth and division of these cells. So this particular tyrosine kinase that we are dealing with in this disease is the BCR-ABL1 tyrosine kinase. This is as we've seen in the pathogenesis of this disease, this is the genetic product of the translocation mutation that we saw. So the BCR-ABL defective gene codes for the BCR-ABL tyrosine kinase. And now these tyrosine kinase inhibitors were developed specifically to block the action of the BCR-ABL tyrosine kinase. So in the 1990s, the development of these molecules was in high gear, which led to the introduction of the very first tyrosine kinase inhibitors called STI-571 and later named imatinib. This was indicated for the first-line treatment of chronic myeloid leukemia, the chronic phase, and also for treatment of the other phases at a higher dose. It showed better survival compared to interferon alpha and cytarabine, and also produced durable response. Unlike the chemotherapy, it produced both cytogenetic and molecular response, meaning it reduced the occurrence of the Philadelphia chromosome and its genetic products, that is the BCR-ABL gene and the BCR-ABL protein, the tyrosine kinase. So the BCR-ABL tyrosine kinases in clinical use currently include imatinib, which is a first generation TKI, bosutinib, second generation, nilotinib, also a second generation, dasatinib is also a second generation, and then we have ponatinib, which is a third generation TKI, specifically developed to overcome some of the mutation that we see that render the CML cancers resistant to the treatment by the first and second generation TKIs. This is the structure of imatinib. It's a small molecule, and it's formulated in a salt, in a mesylate salt. So it's called imatinib mesylate. Mechanism of action of BCR-ABL1 TKIs is every tyrosine kinase, including the normal tyrosine kinases, they phosphorylate proteins in the cell by transferring a phosphate from ATP into the substrate, and therefore activating or deactivating that particular substrate. This process is called protein tyrosine phosphorylation because it occurs on the tyrosine amino acid on that substrate. So this enzymatic change in the cell is what now starts off certain signaling cascade. Now, for the tyrosine kinases to be active, they need ATP, and they have an ATP binding site on them that is now is the active site of this particular enzyme. So, for example, now the defective tyrosine kinase, the BCR-ABL tyrosine kinase, also has an ATP binding site. So this ATP binding site is where the phosphate from ATP is transferred to the substrate via the tyrosine at the tyrosine amino acid. Now this leads to production of the substrate, which is phosphorylated, which leads to the cascade that we talked about, the signaling pathways. Now, the BCR-ABL tyrosine kinase inhibitors work by specifically blocking the ATP binding site of the tyrosine kinases. So being the active site, the imatinib and the related TKIs, they sit close or on the ATP binding site, and effectively they reduce or eliminate the phosphorylation of this tyrosine on the substrate. So the substrate lives without being phosphorylated, and this blocks the chain of phosphorylation and signaling cascade that leads to this cell dividing out of proportion. So treatment of chronic phase CML, as we have seen, there were 3 phases of CML. We talked about the chronic phase, the accelerated phase, and the blast phase or the blast crisis, depending on how many the proportion of blast cells we see in the bone marrow or the peripheral blood. Now, the frontline treatment for the chronic phase, where most patients are diagnosed in the chronic phase, is the TKIs or the tyrosine kinase inhibitors. The currently 3 drugs or 3 TKIs are approved for first-line treatment. This include imatinib, dasatinib, and nilotinib. However, generally, imatinib is the very first drug to be given to all new diagnosed CML patients because it's effective, and side effect profile are also quite manageable as compared to maybe other TKIs in the first line group. The 5-year overall survival has been shown to increase from around 20 to 89 to 95%. So it's a significant change in the management of CML that has been brought out by these TKIs. There's no significant difference in survival or between the 3 first-line TKIs. However, treatment can be individualized based on patient age, comorbidities, any side effect profile that we see with these drugs, and treatment goals, if we want to go into treatment-free survival and all that. So the first-line treatment as seen here in the first table here is imatinib, nilotinib, and dasatinib. As I said, imatinib is usually the first drug that we give at a dose of around 400 to 800 milligrams per day. If there's any intolerance to the first-line TKI, or there's any failure of the first-line TKI or imatinib, then we go to the second-line treatment. So nilotinib, dasatinib, bosutinib, and also imatinib, sorry, are indicated for second-line treatment, depending on what the first TKI was. Failure of the first-line imatinib will lead to using nilotinib, dasatinib, bosutinib, or now ponatinib as an addition as a second line after treatment failure. Failure of first line nilotinib or dasatinib, one can employ bosutinib, ponatinib, dasatinib, or nilotinib, depending on what first line nilotinib was and first line treatment was. Now, third line treatment following failure of or intolerance to this second line TKIs, you can use any of the remaining TKIs. So any TKI that was not in use in either of this line can be used as the third line treatment. Now, following mutation, this particular mutation that we see in around 20 to 33% of patients, about 20% of the patient, this mutation, which is termed T315L, can lead to resistance to first and second line TKIs, in which we only have one option, which is ponatinib, which overcomes this particular mutation. So imatinib as a drug is well absorbed orally. It's given orally. It's, as we've seen, is a BCR-ABL tyrosine kinase, which blocks a kinase inhibitor, which blocks the effects of the Philadelphia chromosome that we see with the disease. The BCR-ABL expressing cells now either undergo apoptosis or the proliferation is severely reduced. This drug is metabolized in the liver, majorly by the CYP3A4 enzyme, which leads to quite a number of drug-drug interactions. Enzymes also inhibited include CYP2D6 and CYP3A4. Elimination of this drug is has an half-life of about 18 hours. So it's given only once a day, and the metabolite, an active metabolite, has a 40-hour half-life. Clearance is through the kidneys, and around 68% may be excreted either through the feces, either directly or through the enterohepatic circulation. Imatinib as a treatment for CML chronic phase is started around 400 milligrams orally. This may be increased to 600 milligram following failure of to achieve desired hematologic response in 3 months. Chronic phase, after failure of interferon alpha, you start at 600 milligrams in absence of severe drug reactions. Disease progression at any time, either failure to achieve a satisfactory hematologic response after at least 3 months of treatment, or failure to achieve a cytogenic genetic response after 6 to 12 months of treatment. Then in this case, we use 600 milligrams, starting 600 milligrams up to 800 milligrams per day. In accelerated phase of blast crisis, we may give 600 to 800 milligrams, whereby the dose of 800 milligrams may be divided into 2 in 400 milligrams twice daily to reduce the iron overload, because the coating of the imatinib tablets usually has iron. Nilotinib as a treatment for chronic phase CML. This medication is also an ATP binding, binds at the ATP binding site of the BCR-ABL kinase. It's well absorbed orally. However, food is seen to increase this drug blood levels. So we give this usually on an empty stomach, so either 1 hour before meals or 2 hours after. It's also metabolized by the CYP3A4 in the liver. So you have issues of drug-drug interactions, drug-alcohol interaction, and also sometimes paracetamol is involved in this kind of interaction. Nilotinib is started at, if used as a first-line treatment, you start at 300 milligrams twice daily, whereby resistant or intolerant to first-line TKI, that is as a second-line use of nilotinib as a second-line or a third-line treatment, we start at 400 milligrams twice daily. Dasatinib as a treatment for CML chronic phase is also a multi-kinase. It's also a BCR-ABL kinase inhibitor. However, it has an expanded kinase inhibition, so it inhibits other tyrosine kinases, not just the BCR-ABL, and it's well absorbed, distributed throughout the body, and eliminated through the kidneys or the feces, and is metabolized through the CY3A4. So again, drug-drug interactions. Dasatinib is started at 100 milligrams for a newly diagnosed patient as a first-line treatment, 100 milligrams once a day, with or without a meal, either morning or evening, can be increased to 140 milligrams per day. In advanced CML as a second or a third-line treatment, we may start this at 140 milligrams and increase it at 100 to 180 milligrams per day if there is inadequate response. So what side effects do we see with this first line or majorly the TKIs? So majorly, we see a lot of hematologic adverse effects. A study at Kenyatta National Hospital, which was spearheaded by Dr. Matilda, they found a lot of cytopenias, anemia, thrombocytopenia, neutropenia being common in people, in patients being treated by TKIs. Sarah also mentioned that blood levels went low a bit after the treatment was started. So there is also issues with fluid retention, edema. There's GI side effects, musculoskeletal pain, and hepatotoxicity with certain agents. Anemia, neutropenia, thrombocytopenia are encountered frequently. They can be treated well. Either anemia, if very, very severe, may be treated with a transfusion. Recombinant erythropoietin may be used to boost the erythropoiesis. Neutropenia can be treated by dose interruption until we have an absolute neutrophil count of 1,500 cells per microliter. Recombinant GCSF is also used to boost the neutrophil count. Thrombocytopenia seen with ease of hemorrhage. So we have gastrointestinal hemorrhage, patients having bleeding issues. This can be treated if the platelets have, if we have a grade 3 or 4 platelet drop or less than 50,000 cells per microliter, then we might we might discontinue treatment as we do management of this type of thrombocytopenia. And we do this, and we might also include a platelet boosting regimen. We might use steroids, we might use eltropopag, we might also go for platelet infusions where indicated. Fluid retention and edema is managed supportively. We also do salt restriction in patients. This disease does not occur in isolation. So patients also have other issues or comorbidities, either kidney, reduced kidney functionality. And in this case, diuretics may be used. We might also do a bit of weight monitoring, salt restriction, and we may also do dose reduction or discontinuation, best until these symptoms resolve. The GI side effects may be managed by ensuring that Gleevec or imatinib is given with food, with a meal. We might also use supportive care, antiemetics, ensuring that the patient takes this in the evening to sleep off the side effects and all that. The musculoskeletal effects may be managed. A lot of patients complain of cramps, arthralgia, bone pain. In this case, we may give analgesics, paracetamol being an issue a bit because of some studies which have shown interaction between TKIs and paracetamol, because the TKIs will increase the blood levels of paracetamol, which may predispose the patient to acute liver injury. Increased fluid intake, or you can give calcium, potassium supplements, tonic water, and other supportive care. For pregnancy and lactation, it is important to note that this medication, these particular drugs, TKIs, are present in, they do cross the placenta, and they may cause fetal harm because they may harm the developing fetus. And in this case, they are contraindicated in pregnancy. So patients are advised to always approach the clinic or their doctors when they want to get pregnant, so that we can assess their clinical status, if they're candidates for interruption of treatment until they get pregnant and deliver, and they can come back to treatment, or if they need to go into another, to go for another, to be changed to another treatment, such as PEG interferon, so that we can also manage the disease during that period. Contraception is key during for women of childbearing age. So we need a contraceptive that at least has a less than 1% failure rate. and this should be demonstrated before treatment is started. And for at least 14 days of a treatment discontinuation, we should have this patient on contraception. Imatinib and other TKIs are present in breast milk, and the patient is advised to avoid breastfeeding for at least even 1 month after following treatment. So we can say that over the last 50 years, the treatment of CML has changed remarkably, and it's a big success since CML as a disease is the only cancer that has shown quite good survival comparable to that of the normal population in majority of the patient under treatment. And the take home from this is that not all fatigue, not all blood deranged tests or all that is normal, or we need to have a bit of a high clinical suspicion level so that we are able to target these patients who we think have CML or any other leukemia, and we are able to bring them to confirm the same or test and confirm if there's any issues with their with their blood or their bone marrow. And eventually we might diagnose more patients on the chronic phase, and the treatment outcomes are always more preferable for patients diagnosed early. So before I take questions or before we conclude, I will also mention the treatment monitoring on either TKIs or any other treatment. So when patients are started on treatment, there are basically four ways of monitoring the patient. So what are we looking out for? We are looking out for to see if one, the clinical, the disease is being managed properly, so the symptoms are going down and all that. Then secondly, we want to see the response in terms of the chromosome levels and the transcript levels. We also want to see the blood levels come back to normal. So we can do four types of monitoring. The two main monitoring methods that we do is the first one is cytogenetic monitoring. So as we have seen, cytogenetics are also involved in the diagnosis, where we identify the Philadelphia chromosome. So cytogenetics are also used, specifically karyotyping, in the assessment of treatment outcomes. In this case, we report on the Philadelphia chromosome in at least 20 marrow metaphases that have been analyzed. So if we find that that the patient has more than 95%, that more than 95% of the 20 metaphases that we are seeing, or cells that we are seeing, if more than 95% show the Philadelphia chromosome, then we term that as not having any cytogenetic response. If we have 66 to 95% of the chromosome of the cell showing the Philadelphia chromosome, then we will say that that is a minimal cytogenetic response. If it's 36 to 65%, we term that minor response. If it is 1 to 35%, that is a partial cytogenetic response. And if a patient has achieved 0%, so we are not seeing any Philadelphia chromosome from this mutation, then we can say that that patient has achieved a complete cytogenetic response. And as we've seen, a complete cytogenetic response is a good outcome, and some patients are candidates for disease treatment-free remission. That means treatment may be discontinued following assessment of all the factors that we consider, and the patient can be monitored frequently to make sure that they remain in the treatment-free remission. So that is the first one, cytogenetic monitoring. Apart from cytogenetic monitoring, we have a molecular monitoring. Molecular monitoring basically, as we've seen, means using the reverse transcriptase method to identify the BCR-ABL transcript. And in this case, we are looking at the BCR-ABL in either the peripheral blood or the bone marrow. Usually it's a blood test that we do. So it's indicated first every 3 months, and then later every 6 months to monitor treatment. And the patient may be termed to be in molecular response following comparison between the levels of BCR-ABL, the ratio of BCR-ABL to the normal ABL or to the normal genetic makeup. So in that case, we are able to say this patient is either in early molecular response. That means if the patient has shown less than 10% of the BCR-ABL as compared to the normal ABL, then we have major molecular response. That means if we have a bigger reduction in the BCR-ABL compared to the ABL, and then we have a deep molecular response, and finally, the deep molecular response is achievement that we are looking for, which shows less than 0.01% of the BCR-ABL as compared to the normal ABL. So those are the two monitoring tools that we use clinically to monitor the patient under treatment so that we can see if they are progressing well. The other tests that other methods that we use are the clinical symptoms, signs and symptoms. So we do clinical observation, palpation of the spleen, and also we look at the resolution of other signs and symptoms, including fatigue and all that. We also look at the blood levels, especially to look at if there is any hematologic response. That means the white blood cells have returned back to normal, and we are having blasts have either disappeared or they're less in the blood. And also we are seeing a return to normal hematopoiesis in terms of the red blood cells and platelets. So those are the 4 ways that we can do monitoring of treatment for patients undergoing treatment on a TKIs or any other treatment. And at that juncture, I think we'll conclude, and I'll take any question from either the panel or the audience so that we can finish today's presentation. Thank you very much.
Thank you very much, Dr. That was very well done. I really appreciate that you've given us very good details that are very helpful in us being able to raise our curiosity level and know that should we come across someone with the kind of signs and symptoms that Sarah displayed, then we know that it could actually be CML as much as it could be anything else, but at least it helps us to know that that could be a possibility, and now we are better equipped to handle that. There are quite a number of questions, which I'm sure we can be able to run through. Most of them you have touched on in the course of your presentation, but those which will need further clarification, I'll call upon you to give more details on. And the first one by Petronila Kingola is there any early diagnosis of this CML for early intervention? Dr. I'm sure you touched on that, but you just clarify that. And while you're on it, you can also talk about treatment and availability and cost of treatment, because it has also come up in the questions.
Thank you. So thank you for Petronila for your question. Now, CML treatment in Kenya is one of the privileged hematology clinics in that it's supported by a patient support program. CML, first-line treatment for CML, which is imatinib, is offered free of charge to a patient, to all candidates for imatinib treatment. Currently, we have this program started many years ago at the Nairobi Hospital, supported by Novartis, who donate the imatinib or Glivec, Max Foundation, who are a big partner in treatment of CML worldwide, and the Nairobi Hospital. The CML clinic that offers this treatment free of charge is run by physicians, the hemato-oncologist physicians, and these doctors give their time free of charge. Every other service is free of charge. So these medications are given free. The service for dispensing this medication is for free. The premises, the doctors, then the triage, the nurses, all those services are offered free of charge in the Mass Clinic, in the Max Access Solutions Clinic, which was initially called GPAP, which is Glivec International Patients Assistance Program. So this treatment, the clinic, the Mass, the Mass Clinic for CML is also supported by other medication manufacturers for the other TKIs. Bosutinib, and the other second and third line, ponatinib, they are also provided free of charge to patients who have either progressed or who are not candidates for imatinib, also free of charge. Nilotinib is currently a medication that is provided at a cost to the patient. However, NHIF is a big partner in reimbursing patients on nilotinib. So treatment is reimbursable by NHIF. So patients, generally CML patients, we are privileged as a clinic to be supported by all the partners in making sure that all diagnoses of CML are treated effectively with effective medication and at a very, very negligible cost as compared to if we are not able to get all these drugs free of charge, then the cost would be much, much, much more expensive than we are seeing. So Petronilla, diagnosis of this CML, early diagnosis can be done by making sure that we are vigilant, more vigilant, so that the population is well advised that if you've been unwell, you've been having fatigue for several weeks, months, you've been having bleeding issues, pain, spleen enlargement and all that, then clinically patient doctors and our hospitals and the referral systems need to be in a good state so that we are able to pick out this, because the very first thing that we see, either apart from the signs and symptoms, is the deranged blood levels, the issues with the complete blood count, where we see a lot of leukocytosis, increased white blood cells up to 500, over 500. And, well knowing that we are supposed to have around 4.5 to 11, but now we have 200, 250, 500, then we are supposed to have actually a query why these white blood cells are this high. And then now following that, we can do a definitive diagnosis, and then we can follow up with the clinic with the referral so that we can able to treat this patient at an affordable cost. So I think I've answered your question. Just to note that the Glivec or is also, imatinib is also used in other it's indicated for a few other diseases. So we provide, the Mass Clinic, we provide free Gleevec for both CML and another type of tumor called gastrointestinal stromal tumor, of which the mechanism of action is still inhibition of a tyrosine kinase, but it's a different tyrosine kinase that is in that tumor. So it's patients also, GIST patients also benefit through this clinic. And but majority of patients are under treatment on imatinib, a few on second line, and a few on third line. Yeah, thank you.
Thank you, Dr. Just a small addition. Besides patients being treated in Nairobi Hospital, from last year, there are 4 other centers that treat CML patients in Nakuru's PGH, that's level 5 hospital, Eldoret's Moi Teaching and Referral Hospital, Oginga Odinga Hospital in Kisumu, and Mombasa's Coast General Hospital. This program was started by the government just some few months ago. So for those patients who are not within Nairobi, can be able to get treatment in those centers. Good thing is that all these treating physicians, they are networked, and they do discuss, they do share notes, and they're able to offer treatment across the country. Other questions, Dr. How are sugars of these patients using TKIs? Does it have effect on their sugar levels? Because I think I heard you mention that the insulin receptors might be affected. So are their sugar levels also affected?
Okay, thank you for your question. Patients, the TKIs that are in use clinically, that is imatinib and related drugs, are specifically targeted towards the BCR-APL tyrosine kinase. The insulin the insulin receptor has been an issue for many years in the development of the TKIs, because it is one of those side effects, that potential side effects of any treatment that will target tyrosine kinase. But imatinib and related drugs have been quite targeted in terms of avoiding the insulin receptor and managing patients without issues with sugar levels. There are some reports of, excuse me, the reports of development of diabetes and all that in patients treated with TKIs. Research is ongoing. However, remember, patients on TKIs or CML patients also have other comorbidities and other risk factors for other diseases. So it has not been shown to be a major issue for TKIs that they would interact and mess with sugar balance in the treated patient. So maybe I can just go straight to the next question. Mr. Edward is asking about why was its chromosome named Philadelphia? So the scientists who were working on this chromosome were in Philadelphia. So essentially that's why it's called the Philadelphia chromosome. Why is CML common in men and not female? Generally, the incidence is the ratio is around 1.6 to 1 men to female. So it's not that, it's significant, yes, but the reasons are not as well understood, because a lot of CML is not, we don't know what causes this mutation. However, There are some risk factors that a lot of people maybe who have CML might have had. These risk factors include exposure to ionizing radiation. For example, people, we've seen people who are in the Hiroshima and Nagasaki cities of Japan during the drop of the atomic bombs in the World War II. They were seen, the population, the CML in that population increased dramatically in years following those incidences. So ionizing radiation is one of the well-known risks for CML. Other risks include previous treatment, family history, previous treatment, either radiotherapy or people who have undergone chemotherapy. But that's not a bigger risk as compared to ionizing radiation. And yeah, so another common question is CML hereditary? So CML is not hereditary. CML is not passed from father to child or mother to child or progeny, because CML is a somatic issue, somatic change. So this mutation does not occur in the gametes. It occurs in the somatic cells, the bone marrow. So that is not transmitted to the progeny or to the offspring. So it's not hereditary. However, the familial risk of cancer cannot be ruled out in that family history of cancer, general family history of cancer may predispose one to myriad of cancers, including CML. What is the cost implication for treatment of CML by using TKIs? As I've explained very well, that is CML is supported by a patient support program. Only in situation where you need to do the testing, either monitoring, where you're doing the PCR, BCR, ABL, PCR, or the genetic testing. In that case, then the cost, there's some cost to it. But generally, the majority of the cost in terms of consultation, medication, follow-up, all that is covered for by the support or the patient support program. At what point should stem cell transplant be instituted? The allogeneic stem cell transplant is the indications for that are one, if a patient is in the blast crisis or in the accelerated phase with failure of the other treatments, then at that point, we might want to try stem cell transplant. Stem cell transplant is also indicated in the younger population because the older population, they are not able to, the side effects of the induction, because you're inducted into total remission, we want to wipe out the bone marrow and then restart it in simpler terms. So that very drastic treatment, some patients cannot be able to, the benefits, the risk outweigh the benefits. So we use that in people who have treatment failure on TKIs, or they have been in blast crisis or accelerated phase. Thank you.
Thank you very much, Dr. Dennis. I know there are quite a number of questions, but we've run out of time. We may not be able to respond to all of them now. But what I can advise you to do is just check out on the Kenyan Network of Cancer Organization website. You'll be able to find more resource materials on CML and other cancers. You can also check with the Henzo Kenya website. You'll be able to get that. And I'm sure Dr. Dennis's presentation is going to be availed to you by mail at a time that will be advised. So, but there's just one question. Let me just respond to that one very quickly. Someone is asking the prevalence of CML in the country. We cannot exactly say how many people have CML in the country yet, but at least there are 1,600 odd people who are currently on treatment in the centers that I've mentioned, in Nairobi Hospital, Kenyatta National Hospital, like Khan, Hospital in Nairobi, and the other 4 centers in Kisumu, Nakuru, Eldoret, and Mombasa. So there are at least 1,600 people who are currently under treatment, and most of them are doing well. So then, ladies and gentlemen, we may not be able to continue past that. Sincere gratitude from every one of us, from KNCO for setting these up, from the partners that have helped KNCO put these up, including Janssen Pharmaceuticals, and of course, KNH. So thank you so much from me. Thank you, we really appreciate it. And I want to send you back to the organizer for further announcements. Asante sana.